I'm Farhad Ravandi. I'm from University of Texas MD Anderson Cancer Center. We are here at the International Workshop for Acute Leukemias, and we just had a session on minimal residual disease assessment in acute myeloid leukemia. With me are Dr. Marion Subklewe and Dr. Adriano Venditti, and they were at the session and were discussing their data. I'm going to first ask Dr. Subklewe what her thoughts are on the subject of minimal residual disease assessment in AML.
So I think we should still be aware that MRD assessment in AML is still lacking behind MRD assessment in ALL. So we still have no harmonization and no standardization in either flow-based or molecular-based MRD assessment. And therefore, the trials that have been reported, the results, most of them are retrospective analysis, are very difficult to compare, and these are just still very early days. I think the ELN paper published in Blood is now giving a platform for harmonization and from comparison between different study groups and different trials. And clearly MRD positivity is a prognostic marker that has been shown consistently in most of the studies, and clearly is a point for clinical trials for interventional studies.
Dr. Venditti, you were one of the pioneers of flow data. I think you first published your paper roughly 20 years ago?
More or less.
More or less. So what are your thoughts on flow cytometry versus other techniques that are being used for minimal residual disease assessment in AML?
Well, flow cytometry was one of the leading techniques used together with molecular biology. I believe that we made some substantial improvement. For instance, the possibility to shift from 3-4 color assay to 10-12 color assays, and this can provide us with an improved sensitivity. Of course, flow cytometry does have a very strong competitor, such as NGS, for instance. But I believe that at the present time, NGS is as the same situation as flow. Even NGS still lacks standardization, harmonization. But I also think that we have to be realistic with regard to this point. We have so many different therapies. We have so many different molecular targets or phenotypic targets. So we need robust tests that are validated, but I'm not sure that we will come up with an harmonization.
Now, flow cytometry is a lot more dependent on the person who is evaluating. Do you feel that NGS could be a more easily standardized assay to use in this setting, or do you think they can be equivalent?
Clearly, flow is more person-dependent on the evaluation, so there are different strategies to overcome that. First of all, samples are just sent to a centralized lab, and thereby overcoming, so we have sort of one team to evaluate it. Or there are strategies that you only do the wet lab, the measurement, decentralized, but then the files are just going to a centralized lab. So that would be a strategy to overcome the subjectivity of the assessment, and clearly you can make sort of trained centers, maybe 4, or depending on the size of the country. But there is, in molecular diagnostics, NGS, a more objective form, but I think the difficulty is going to be the threshold, and that's going to be very difficult with NGS, and it's going to be treatment related. What threshold is going to be relevant? So I think there's still a lot of work also for NGS.
And also we've seen some mutations who can persist in remission and be not predictive of relapse.
Right.
And in terms of flow, there's a lot of European data in ALL, as well as using molecular PCR techniques for IGH PCR, as well as T-cell receptor PCR. Is there anything to suggest that the Europeans are going one way or the other, at least in ALL, acute lymphoblastic leukemia?
Well, perhaps yes, at least in ALL. Actually, the main protocols, although assessing MRD even by flow, but as a matter of fact, are PCR-based, especially when it comes to make clinical decision. And definitely yes, in ALL probably the researchers are pointing to molecular biology.
Although in ALL you have to have it is patient-specific, the IGH and T-cell receptor, so it's very cumbersome. And I mean, obviously in European centers you have centralized lab. I'm not sure if that could be translated to US studies, and I personally think in ALL, in the US, flow probably is going to be the way. In AML, perhaps, I don't know, NGS could become established as, in the US at least, because of, again, the multiplicity of centers and the high reliance on the operator of the flow analysis, which has not, at least as yet, been centralized in the US.
Yes, you are right, but I still believe that flow in AML has a relevant role, depending upon the observation that beyond NGS, that is something that is to be established in the common practice. Beyond NGS, actually we have very few stable markers. I mean, the main one being NPM1, but we know that other markers are not as much stable as we would like to follow up MRD. Perhaps we have core binding factor positive AML, but just let me mention the case of AML in children. Dario Campana and this group demonstrated that flow cytometry remained the main approach to follow up MRD, because in children AML, even NPM1 is not useful, because NPM1 is mutated in less than 10% of the cases. So there is no marker available to be followed up, and MRD by flow remain the, let's say, a cornerstone.
Or perhaps there be a time in the future we can actually combine the two together, because they complement each other. If we will have both standardized, and obviously using both together is likely to increase the reliability and sensitivity.
Absolutely. Sorry.
Can I also comment? Yeah, I think both techniques will be very valuable if you think of personalized, individualized treatment strategies, because also phenotyping will give you the information of targeted therapy, immunotherapy. It will also be valuable if you can analyze MRD cells relating to phenotype and genotype, so you will have the target assessment and possible resistance mechanisms of these cells. So ideally, you will have the MRD cells analyzed and then off the shelf use a suitable strategy for MRD eradication. So that could be something.
Which actually brings to the most important point, that MRD is irrelevant unless we have something to deal with it or eradicate it.
Yeah.
And that means that we need effective agents to eradicate MRD. We're already seeing blinatumomab in ALL. We hopefully will have similar bispecifics in AML. And any thoughts on that?
Well, we have the renovated role of Geos.
Geo is a possibility, yes.
We have other monoclonal antibodies on their way.
So are you using Geo for MRD eradication? And
Well, in the next GMEMA trial, we are planning to use Geo to reduce MRD, but not before transplant because of concern of VOD, but adding a Geo in induction and consolidation therapy, and whether and to check whether by adding Geo the level of MRD can be reduced even further.
well, look, I mean, one could argue that if you use a very small dose of Geo, if it's shown, if it can be shown to be effective to convert an MRD positive to MRD negative, it could be relatively safe for transplant if you are using a dose like 3 milligrams per meter squared, or a very tiny dose, essentially.
Yes, but there are data suggesting that a small sequential dose of 3 milligram per square meter, for instance, the same schedule that was used in the Alpha study, 3 milligram per square meter on day 1, 4, and 7. Well, this schedule is quite effective in decreasing the level of MRD. This was demonstrated by checking the number of NPM1 copy transcript.
Okay.
And I think MRD is an ideal setting for immunotherapeutic approaches. So, I mean, we've learned already from Blin, as you said, that it's most effective in the MRD setting. So I think the study that was published by Platzbecker on azacitidine, which is also immune modulating drug, increasing leukemia-associated antigens, modulating T-cell responses, might be something that's worth continuing, maybe even in combination with other drugs. And then clearly T-cell engagers might be something that's really suitable if you have still a functional T-cell compartment that might be useful in this setting.
Well, I think that was a very interesting session on minimal residual disease. I think not just from this session, but from the entire day's talk, it's clear that minimal residual disease assessment is important in acute leukemias, and obviously there's a lot of interest in developing agents in this setting. And as we all know, there are potential immunotherapeutic-based strategies that are in development.